Welcome. So I think it's time to start this webinar, which has been organized by the School of Urology of the EAU. So I'm really happy as a moderator to welcome my colleagues. My name is Morgan Rouprêt. I work in Paris, France. I'm the chair of the section of onco-urology of the EAU. Tonight we have two eminent guests and colleagues implicated in bladder cancer. This is fantastic. We have Prof. Liedberg from Malmö, Sweden. Hello, Frederick. Good to have you on board. He's a member of the guidelines of the EAU, non-muscle invasive bladder cancer panel. And we have Professor Xylinas from Paris as well, who is from Bichat, University of Paris. And hello, Evangelos. Nice to have you on board. Hello. Member of the guidelines as well of the EAU, the French guidelines, and also the School of Urology. So we have chosen together to go through difficult bladder cancer cases, which means that it will be open to discussion. It has nothing to do with, I would say, a formal lecture. We would like to have interactivity, and there is room for question. So for that, and to avoid, I would say, noise disturbance, we will use the chat box, and you can raise any question you would like to see, and we will discuss it together with Frederick and Evangelos. So this is the way we should proceed, and you have all the instructions that are already displayed in the chat box from Yogita, and I think on behalf of my colleagues, we'll start by thanking Yogita for involvement in the organization of the webinar. So anyway, right away, we'll start with the case number 1. So Frederick, if you don't mind, let's open the webinar and discuss your case and see how we would have dealt with this situation. Thank you.
I don't mind at all, Morgan. Thank you very much. And good evening, everyone. And thank you to the organizers for inviting me to this urothelial webinar. And to accomplish this interactive discussion, I would like to share with you a Swedish case that we have had within recent in my institution, and discuss how things were performed, how things were done, what happened, and if we can learn something, anything from the course of this 62-year-old male's disease course over the years. So this is a non-Swedish citizen, so he's non-native Swedish, so to speak, and he came to the Department of Urology related to macroscopic hematuria, and the conventional investigation revealed multiple bladder tumors, as you can see from the late excretion phase. Multiple tumors, less than 3 centimeters. He had a previous medical history with rheumatoid arthritis, where he was prescribed at diagnosis methotrexate to reduce the inflammatory burden and disease from his disease. Otherwise healthy, and no history of smoking previously. So based on this CTU and the cystoscopy, he was subjected to a transurethral resection, and the resection was performed, and you can see the lovely orange or pink path illustration, where lamina propria invasive tumor infiltrating fairly deep into the lamina propria is to be seen. And as this was a T1 tumor, no concomitant carcinoma in situ, the patient was subjected to a second look with a re-resection of the scar. And when that was done, a couple of weeks later, he was discussed at the multidisciplinary tumor board. And there were no resection biopsies from the prostatic urethra obtained, neither from the primary section or the re-resection, although the voided cytology revealed Paris 4. Based on the knowledge so far, we consider this as a high-risk tumor using the EIU 2021 prognostic model. The resection was performed and it was a good bite, no remaining tumor, and you can see from this pathological slide from the resection where the desmin is colored brown. There was plenty of muscular tissue in the resection, but no viable tumor. So apart from the EIU prognostic model and the fact that this was an extensive lamina propria invasion, the patient was recommended bladder preserving treatment with BCG rather than primary cystectomy. Eventually received BCG and 6 courses of induction started last spring. But at the first cystoscopy, there was a reddish area in the bladder dome, and the patient had Paris 3 in the voided cytology. So the urologist did a biopsy in the outpatient clinic, and it turned out to reveal normal urothelium, no visible tumor. So the patient.
Frédéric, sorry to interrupt you.
No, you don't interrupt, please.
No. I just want. It's just I would say daily practice urology. Very interesting what you are showing there, or about tips and tricks. And I would like to involve also Evangelos in the discussion, because you are telling us that you have the opportunity when you do a daycare cystoscopy to perform, I would say, a biopsy on a regular basis. Is that right?
Yes, but this is, a biopsy through the flexible scope, which means a much smaller
so it's
biopsy.
Tiny bites of tissue. First question to Evangelos: do you do that in your practice, and do you have the opportunity to do that as well? I cannot hear you, Evangelos.
We don't have this opportunity to do that in office-based practice, so no, we don't do that.
Oh, okay. And question back to Frédéric. Contingent upon the fact that the biopsy was negative, can you base your upcoming strategy just on the outcome of this biopsy? Do you believe that it is a sufficient amount of information, or do you consider this just as, I would say, information like you would have frozen section analysis in any, I would say, radical surgery? What is your opinion about this biopsy? Because it's quite uncommon. So this is why I take a bit of time to discuss this point.
Absolutely, and it's one of my main messages. Actually, I think we overestimate the value of these small, tiny biopsies, because it's only my opinion, because there are not much literature or evidence around it, but it's my impression from my clinical practice that you might both miss tumors and overstage tumors. And another thing is, in this setting, when you have given 6 courses of BCG, it's not unusual that you have Paris 3 in the voided cytology, because it's part of the disease course. It might take even longer than 3 months to have the voided cytology to convert into normal. So that's a really good question. And then I'll tell you what happened afterwards, because he was scheduled for maintenance BCG, but it was postponed because he had some local complaints, and it was difficult for him to communicate that with his urologist. But finally, he started a couple months later, and he received 1 BCG course, but was then hospitalized due to bladder pain after 1 maintenance instillation. And during that hospitalization, this was his radiology. And as you can see, there were a large extravesically growing tumor in the bladder, which is a point I want to make. This biopsy was from the area, but it didn't capture the deeply invasive tumor. And you could also see extensive retroperitoneal lymphadenopathy. So this was a completely different disease at this stage. So the four things or reflections that I would like to have your input on is what is the role of radiology in high-risk non-muscle invasive bladder cancer. As you can see by the red arrow here, this is a large lymph node, 10 millimeter diameter, that was present already in the original radiology. So maybe if we could have done a better job at the MDT when we discussed the primary treatment for the patient, and what is the role for surveying nodes and the local status in the bladder for high-risk tumors. Another thing that can be questioned or considered in this case, where it didn't turn out very well in the end, is whether we should rely on these flexible cystoscopy obtained biopsies, where we obviously in this case definitely could not. And I think to rule out malignancy in case of unspecific bladder lesions, these small biopsies are frequently too small, and we should more rely on cytology and the endoscopic view. And
okay,
yes,
Frederick, sorry, following up on what you just mentioned. There is a question from, or suggestion maybe from Dr. Roberto Carando, who says that, what do you think about cystoscopy and washing cytology as routinary control and not routine biopsy in course of flexible cysto and no macroscopic lesion in case, I think. So
the question is very good. It's a question, what about bladder washing versus voided cytology? And there are actually a couple of studies, and the major of those studies are performed 2 or 3 decades ago, and they were done with putting a cystoscope sheet into the urethra and really rinsing the bladder with a syringe. In that setting, the bladder washing had a higher sensitivity, but in more modern series and obtained through the flexible cystoscope, the sensitivity is the same when it comes to bladder conditions. But more importantly, the sensitivity for urethral lesions and even upper tract lesions are much less if you do the bladder irrigation. So that's why I, as a routine, perform voided cytology instead, to have the possible contribution of cells also from the upper tract and from the prostatic urethra and also the distal urethra. So I think especially during follow-up of high-risk disease, where we know there is a good sensitivity of cytology, we should apply the voided cytology, although there are no randomized trials comparing in that particular setting. So in my practice, these small biopsies obtained under local anesthesia is mainly to verify a recurrence in a patient with a low and intermediate risk tumor prior to fulgurating it in the same session in the outpatient clinic. So my 2 final things to discuss is, could this patient's methotrexate have contributed? Well, in fact, he was changed to steroids during the induction course. But what are the guidelines? What are the knowledge and evidence behind these different types of immunosuppressive drugs that become more and more frequent to use in patients today? Should we give them steroids and treat by BCG, or should we use other treatments? Should it be a fact to balance against radical treatments? I don't think anyone really knows. And my final sort of comment and suggestion to improve the outcome of these patients is in line what's now in the European guidelines, and that is a multidisciplinary tumor board where you include the cytology, the radiology, and the pathology, and review the pathology is a way to improve the outcome for these high-risk non-muscle invasive bladder cancer patients. And that's why it's in the guidelines in this year's version, although the evidence is weak. So I'm happy to discuss this further, and I actually don't know what the common practice among different countries are. We have for many years practiced multidisciplinary tumor boards as an obligatorium in T1 disease, but based on the data supporting altered treatment in these patients, but I don't know if it's systematically performed globally.
Yeah. Yes.
So thank you.
I think, Frederick, thank you so much for your presentation. I think it's there is room for discussion. On top of that, we have also Bas van Richt, who is connected, our colleagues from the guidelines that you know perfectly, and Bas has added in the chat box a reference about the potential added clinical value of PET FDG CT to stage patient with high-risk non-muscle invasive bladder cancer before radical cystectomy. So I don't know personally this reference in particular, but would you like to expand on that? And do you feel that it is relevant, today?
Absolutely. If this patient, if we detected this para-aortic node at the MDT, we would directly have performed FDG PET-CT because it might increase the sensitivity to detect lymph node metastasis compared to ordinary CT. And especially if you're going to do radical surgery in the high-risk patients. There are, however, different studies depending on which kind of patients you include, and although it's prospective trials, depend on the risk of the particular patients, including the cohort when it comes to additional findings. But I think PET-CT is an opportunity to strengthen the preoperative evaluation of high risk and especially very high risk patients, and added on different risk factors for progression or metastatic disease, such as histologic subtypes, lymphovascular invasion, which is associated with lymph node metastasis. I think this is a feasible and recommendable, although the evidence is not very strong yet.
Okay, coming back to the MDT point, because you made a point about the organization and the fact that it's more or less mandatory to discuss at least T1 cases. I would say on our side, maybe Evangelos in France, we are supposed to register every cases of cancer. But anyways, there is not that much discussion in the field of non-muscle invasive bladder cancer for the simple reason that the people sitting around the table, I mean, we have medical oncologists, radiation oncologists, nuclearists, radiologists, they don't really feel involved in that setting where we should put a lot of energy, because 80%, 85% of our patients belong, at least in Western Europe, belongs to the, I would say, non-muscle invasive bladder cancer group. So I think also it's a question whether or not the MDT has the opportunity to offer, I would say, clinical research protocol to the patient, because it depends whether or not we are active as urologists in the field of clinical research. Because you mentioned many options that are not really in the guidelines, but that are potentially interesting for the patient. But outside, I would say, the frame of the clinical research, there is no way we could prescribe this. Am I right? What is your position, Frederick, and maybe Evangelos around that?
Absolutely, I agree. The MDT is a very good arena for discussing inclusion in clinical trials. And in fact, we do it every week, but we should also, I think, another dimension is that we train together the radiologists, nuclear medicine physicians, pathologists, geologists, oncologists. So we need to discuss every case. And I mean, to sample the prostatic urethra was missed in this patient. If we got another risk factor for progression, such as carcinoma in situ in a biopsy, if it was obtained, it might have altered the treatment recommendation for this particular patient. So every patient is a way to train the team to perform as accurate and precise diagnostic and treatment measures as possible. So I think we train ourselves. I train myself every MDT, and I use the MDT app, the risk calculator, just to sort of as a way to treat every patient systematically.
Okay, Evangelos, your point of view from the role of the MDT and the input that we can obtain?
Yeah, I think that definitely MDT is a good point. We do use it in France in every cancer cases. As you mentioned, Morgan, the real question is, do we re-review all the CTs of the NMIBC patients? And the answer, unfortunately, is no. And you can see that in these specific cases, it would have changed probably the decision-making towards perhaps an induction chemotherapy. And I do agree that if we had re-reviewed this CT scan upfront at diagnosis and suspected lymph node involvement de novo, then we probably should have performed a PET CT with FDG, definitely to help the decision-making. And I think that this is very important as a message that perhaps 5 to 10% of T1 high-grade patients, they have lymph node involvement. And we do know that from the radical cystectomy series of patients with T1 disease. And I do agree that these series have a selection bias because these patients underwent radical cystectomy. But still, these are numbers we do have in the current literature to support perhaps re-review of these CT scans in an MDT board.
Yeah, that is certainly important. We went through certain borderline cases, I would say, or difficult cases, and we had an experience in France a few years ago where I asked the responsible of different MDT to accept to present a similar case anonymously to different, I would say, school of medicine. And we have seen in that experience, which is much more, I would say, eminence-based than evidence-based, that there was a local influence of the, I would say, local habit according to catchment area where the cases were presented. And I think outside the literature itself, it is clear also that there is an influence on the way we are trained. We all know that when it comes to muscle-invasive bladder cancer cases, some people, for a reason or another, are reluctant to the prescription, for instance, of neoadjuvant chemotherapy, or they are saying that it should be restricted or only a few cases. And we can see that it has an influence on the decision of the people who are working there. Do you feel that it is true also, or do you see that there is no discrepancy between the guidelines and the reality of the practice, Frederick, in your practice?
When it comes to the particular setting of T1 disease, I think we have a fairly homogeneous way we discuss patients at the MDTs. It's defined in the national guidelines. It should be reviewing radiology and pathology, and also measuring the proportion of patients with T1 disease recommended radical cystectomy, and that finally are subjected to radical cystectomy has about the same proportion over the country. So I don't expect any large differences, but there might be differences globally on the way we recommend patients treatment. That's not unlikely.
Okay.
But I think the MDT is a way to also level the treatment proposals to the same sort of evidence and practice patterns within and outside countries. And that's why I think the current recommendation in the EA guidelines is important, because it's a way to discuss the problem rather than every MDT or every urologist perform what he or she thinks is the best for that particular patient.
Yes, certainly. If you hear me correctly, there is another question coming from the chat box. but which could be a topic of a full webinar by itself. What is the current situation of biomarkers in NMIBC? So maybe, you know, in the guidelines, we're always saying from a year to another, it's interesting, but it cannot be implemented yet, and so on and so on. Any use in your practice for surveillance follow-up or for the diagnosis, maybe? If you can summarize what is your behavior at the moment, both of you.
Well, Evangelos can start then.
Yeah, I think that currently there is nothing new in the diagnosis setting. In the surveillance setting, some modern, I would say, urinary biomarkers have shown great data in terms of negative predictive value, especially for high-grade disease. So they don't miss high-grade disease. They don't have yet the evidence to support implementation in daily practice because they haven't shown that they can replace the combination of urine cytology and cystoscopy.
Okay. Frédéric, on your side, any ongoing trial, or are you enrolling patients?
There are ongoing Swedish trials in the diagnostic setting with urinary markers, but it's nothing used in clinical practice, and it's not paid by the health authorities, so it's currently not used.
Okay.
Cytology is the basis, and we do not recommend cytology in low grade and intermediate risk disease.
Okay, going back to the case, another question is popping up in the chat box. Does the panel believe in having a second resection or a second look if the surgeon is confident at the time of resection about clearance of tumor with muscle being present in the first resection specimen? So do you stick with the concept? The colleague is anonymous, so I don't know his name, but he's asking because almost in all cases, the decision of next steps can be made if all the information mentioned above is available. So what is your perspective from the second look? Do you have a personal opinion outside the guidelines?
No, but I mean, one opinion is the case I presented. There was muscle in the specimen, both in the primary resection, in the re-resection, and especially if you have multiple tumors, where should you go for the re-resection? So there are obviously caveats that you need to consider, and to recommend refraining from second look resection, I think is difficult as a standard of care based on presence of the tumor in the primary section.
Okay, perfect. No more question. I think we are perfectly on time to switch to the other cases, which is going to be presented by Professor Evangelos Xylinas. So Evangelos, the floor is yours, but we stay online, and if you don't mind, we can interrupt you from time to time.
Yeah, I'm gonna challenge you. So second case, I would like to talk about the case of synchronous NMIBC and upper tract disease, which is a common question, I would say, in daily practice, and not always easy to deal with it in terms of organization, decision making towards therapies. So this is a case of a female patient, quite healthy female patient, 70 years old. She had a previous history of bladder cancer, a TA low-grade non-muscle invasive bladder cancer treated in another center, diagnosed some time before and treated with adjuvant mitomycin as an induction treatment, no maintenance. She had also a hip replacement surgery a year before that bladder cancer, and she was referred to our Center for Recurrent Bladder Cancer. So she's a retired designer. She has one daughter living in Australia and no grandchildren yet. And she wants to see grandchildren before leaving this earth, is exactly what she said when I met her. She's perfect condition, no smoking exposure, no family history, no hematuria. She was diagnosed based on low urinary tract symptoms. You can see her labs with a perfect estimated GFR of 83. So we did a TURB based on a cystoscopy report, showing multifocal disease, 5 lesions, 1 to 2 centimeters, basically right part of the bladder, left part, the bladder neck, and also the dome as the previous case. And we did a TURB. My first question is CT urogram, and I think that definitely the answer is yes, based on the case before. And this is the CT urography and urogram. I'm showing you as a video showing on top of these bladder cancer lesions, a multifocal upper tract disease of the renal pelvis, right renal pelvis. You're going to see it here, multifocal. And also, when we go down, you're going to see also a second location on the right iliac ureter. So definitely a multifocal upper tract urothelial carcinoma like. So the first information is UTUC and NMIBC, either as synchronous and also as metachronous disease. And I think this is a very important question, because we always think that we do a CT and that the, I would say, the detection rates are quite questionable, and that it's not very useful always due to the low incidence of upper tract, which is below 2%. Of course, some risk factors of synchronous upper tract have been shown in the QRT literature by Juan Palu, actually, who was chair of the school. So that was funny to find a reference from his center, showing that when you have a trigon location of a bladder cancer, bladder NMIBC, it increases your risk of having a synchronous upper tract. Also, during the follow-up of NMIBC, the risk of upper tract increases when you have multiple tumors and also high-risk tumors, as being shown by this also publication from Foundation Pigler. So my first question to the panel is for the evaluation of this synchronous upper tract disease on an NMIBC looking bladder, do you do imaging alone, as we did here? Do you complete the workout with in situ urine cytology, or do you go further to a diagnostic ureteroscopy plus biopsy at the time of TURB? So I'm going back to the panel to ask, let's say, Frederick, what would you do?
Well, you've shown very nice CTU sections in late excretion phase, and if you have a similar corticomedullary phase where you can see that these multiple lesions are contrast enhancing, and you have a patient with bladder tumors, I wouldn't do anything else. I would trust the imaging. I would not go for neither in situ urine cytology or diagnostic ureteroscopy, because it wouldn't alter the treatment. This is a multifocal upper tract where the standard treatment is obvious. So my response is no, I wouldn't do anything else.
Yeah, it's always a difficult question to know if you do like a diagnostic ureteroscopy, especially if you go to do a TURB. It's always difficult. So we decided to do in situ urine cytology showing atypical cells, and based on that, in the multifocal disease, classifying this upper tract disease into high risk, as you mentioned, upper tract. We didn't do ureteroscopy and we didn't do biopsy. Moreover, the left kidney, you saw it, was functional with a perfect EGFR. So the decision was to, based on these results, to move forward to RNU. A small question that is always, you know, a daily practice question, especially among our fellows doing these emergency cases sometimes, is if you have like a TURB and you have an obstruction with an upper tract or without upper tract of urothelial carcinoma, but an upper tract obstruction, do you put a nephrostomy or a double J stenting? And there is this common sense of saying that if you put a double J standing, there is a risk of dissemination of the bladder cancer cells into the upper tract. I wanted to address that question with the recent evidence in showing this study from Germany comparing double J standing and nephrostomy placement during TURB, and does it impact the metachronous upper urinary tract urothelial carcinoma occurrence? And basically the answer was no, so no difference between nephrostomy and double J stent. And this is a question I think that most of us has in daily practice. And I think there is no evidence right now to support one option over the other. And so I wanted to discuss that because I think this is an important when you have a TURB and also an upper tract, or you don't want to disseminate. So we did the TURB, and the pathological report showed a TA high-grade disease without CIS, muscle seen, and also mucosa seen without disease. So TA high grades, high risk NMIBC. Then we did the RNU. So we started with the TURB, and I will explain why, because we wanted to clean the bladder in order to do a bladder cuff, and then to decide after the RNU, the adjuvant treatment. And here you have the pathological report of the RNU, which was a laparoscopic robotic assisted RNU with a bladder cuff, showing what we expected, a multifocal upper tract disease, a TA, high grade into the renal pelvis, and low grade into the ureter, no CIS. And my next question is, would you do differently? Would you do a different sequence between TURB and RNU? What are your thoughts about it?
Well, if I can speak about that, I think it's logical to treat first the upper urinary tract. So you were discussing the case of the double G and the nephrostomy. And I think that we all know that after a radical nephrectomy, there is room for, I would say, recurrence within the bladder. Yeah. So I would feel more comfortable to secure the upper tract first, where there is a radical surgery. We are in a situation where we have two functional kidneys. It seems logical to do the radical surgery. And the subsequent question is whether or not we'll be in a situation to preserve the bladder. And according to this, there is room also, but we did not discuss the way you handle the bladder curve in that particular setting, and whether or not you will do instillation after, because some of the colleagues, and as far as I know, in our practice, it's quite difficult to deliver chemotherapy immediately after the radical nephrectomy, and it is mentioned in the guidelines. So the question is the right timing around that, and we know that the sooner is the better, probably in terms of good impact on the oncological outcome, but the later is the safer in terms of, I would say, bladder scar. So in that particular setting, I would reevaluate the bladder, I would say by an endoscopy, and then treat the patient according to a regimen of instillation that I would do in a bladder tumor setting, contingent, of course, taking into account the continuum between the urothelium of the upper and the bladder tumor. So I would skip the bladder instillation as mentioned in the guidelines for regular nephrectomy. And maybe we can expand the discussion with Frederick. But can you tell us the way you have handled the bladder cuff, any particular technique in that setting, or no endoscopic management because there was a bladder tumor?
No, yeah. So we did the complete TURB, and then we did a classical RNU with bladder cuff, based on the fact that we did a complete TURB prior to the RNU. So we did a standard bladder cuff, like a transvesical approach, where you open the bladder and you go and you take the whole bladder cuff out. I think that your question and your discussion on single postoperative instillation of chemo, and I had a slide on it, so this is a very nice transition. came from this prospective trial from O'Brien and the British colleagues, showing that a single postoperative instillation of mitomycin decreases the risk of intravesical recurrence after radical nephroureterectomy. And I think that's evidence. The real question is, how do you do it and when? And in this trial, the instillation was performed at the time of removal of the bladder catheter. And that was performed between 2 and 11 days at discretion of the institution and of the surgeons, showing that, as you mentioned, Morgan, there is discrepancy in the belief that we can do that single postoperative instillation early or later after radical nephro-U, and depending on the confidence we have on our suture of the bladder cuff as well. And the real question here is, does this single postoperative instillation in this particular case where you have a bladder cancer, high-grade bladder cancer, you are gonna give adjuvant BCG probably to this patient. Is there any benefit in doing this single postoperative instillation as you are gonna perform adjuvant induction BCG?
Okay, thanks a lot.
Frederick,
you are done with presenting the case, but I have a question from the chat box. Would inserting a PCN be beneficial for injecting chemotherapy in case of synchronous upper tract tumor?
So this is so the question is about intra upper tract instillation by percutaneous nephrostomy. I think that has some low-level evidence when you are envisioning a conservative management of an upper tract disease, which is not the case here because she had a high-risk disease. So there was no question of an elective conservative treatment and no imperative conservative treatment as well because she had 2 functional kidneys. So you do that when you are in a phase that you want to do a conservative treatment of a low risk upper tract disease, I would say.
Okay, Frederick, you
well,
want?
I think no, I completely agree, and in my head, this tricky case is balanced by the recurrence risk in the bladder from the bladder cancer disease and the upper tract disease, and the risk of recurrence is mainly related to the bladder cancer here, and that's why I think we should apply the evidence for bladder cancer, including serial installations of BCG as she previously received mitomycin. So I think I would have applied the same sequence and reasoning as you did, Evangelos, because I think you get additional information from the path report after the TRB that further suggests adjuvant BCG or adjuvant serial chemotherapy installations in the bladder. And there is, in fact, an Egyptian trial where they compared single installation after RNU versus serial installations, and there were no obvious gain by adding serial installations in the setting where you only treat the upper tract. So we can, based from that trial, also find support for the strategy that you suggest, Evangelos.
Yeah, I think, yeah, it's exactly that, like TRB, RNU. I think Bas is pointing the question of doing TRB when you have the answer of a TA high-grade disease, so high-risk NMIBC. The question is, do I go for the BCG induction and then I do the RNU? I think that there is pros and cons. I think the pros for performing RNU is that you do not delay the treatment of this upper tract disease, which is multifocal, so a high-risk upper tract disease. I think that the cons is that you're going to delay the treatment with BCG and then, of course, increase the risk of bladder recurrence. There is no good answer. You cannot do the two together. That's definitely the case. We also, to explain that, we also chose to start with RNU because we thought that due to the multifocal disease, perhaps the PATH report would show invasive disease of the upper tract, so more aggressive, and then it could be a discussion of adjuvant systemic therapy after RNU, which and disease that may have impacted the or life-threatening disease of the upper tract compared to the TA high-grade NMIBC of the bladder. So that also was part of the question of the pros and cons of the this sequencing strategy. And I just put here one slide on the adjuvant systemic therapies we have that have been shown to improve disease-free survival in upper tract disease. And we are fortunate to have the PUT trial showing the benefit of adjuvant platinum-based chemotherapy after RNU compared to surveillance, decreasing approximately by half the risk of recurrence. And we have also evidence now with adjuvant systemic immunotherapy with a PD-1 inhibitor, nivolumab, showing also an improvement in disease-free survival, especially in tumors expressing PD-L1, and we have approval in Europe. So these two therapies are approved and available for European patients. So we have to also keep that in mind for the decision making, I would say.
Evangelos?
Yeah.
Well, okay. We have some question coming from the chat box. Would you like to finish and then go back to the question that are not directly related to the?
I think we finished with this case because it was a PTA high-grade upper tract disease, so there was no no indication for an adjuvant treatment. But I wanted to discuss that because, of course, it can also be balanced. If you, for example, had a PT2 N0 disease, and I will transition to the lymph node question.
Yeah, that is exactly the one I would like to take.
It would be a great indication for adjuvant cisplatin-based chemotherapy in these patients, and we also could discuss the sequencing of this adjuvant chemo and the intravesical BCG induction therapy for the bladder cancer. So this is not easy questions. There is no good answer, I would say. And the lymph node dissection you perform, lymph node dissection in upper tract, no as good evidence as bladder cancer. It is in the guidelines that we should perform lymph node dissection, which is based on the location of the upper tract disease. So in this case, it would be lateral to the cava vein and going down because you had also the lesion of the iliac ureter. So you should do also lymph node dissection of the iliac anatomical template as well. So it's what we did in this case, and it was negative.
Okay, perfect. So going back from the bottom of the chat box to the upper question about more tips and tricks. Do you really have a serious concern about tumor spreading during percutaneous nephrostomy treatment with BCG for upper tract?
So honestly, I don't have a huge experience. These are very rare cases. I think it's one in every 5 years. So honestly, I don't really know. There's no good answer, I would say. The real question is, why do you do this treatment? It is probably because you don't have any other choice. So I think the concern has to be balanced with the choice.
Well, I agree. We have had cases with metastatic deposits within the nephrostomy tract after RNUs, and if you have high-grade disease, I'm very reluctant to put in a nephrostomy tube or to prevent that. So I think, as Evangelos suggests, it's purely on imperative indications, and we even use double J, where we during the anesthesia do an cystography with 150 ml in the bladder and slide to Liedberg to see if that particular patient has reflux enough to have a go with intravesical instillation and retrograde propagation through the double J stent, which is not always the case, but that's a problem when you put in a nephrostomy tube in a high-grade disease.
Okay, certainly. And we have also Christian Falkenhauser from the board of the ESA, who is connected and mentioning that BCG is contraindicated in case of gross hematuria. What about hematuria after LNU, I believe? Is gross hematuria contraindication for post-op mitomycin instillation? In his practice, he's sharing his habits with frequently observed that after radical nephrorectomy with bladder cuff, you're always unsure whether to do or not to do post-op mitomycin. Reflecting, I believe, what we all feel. It appears to be relevant to do the mitomycin instillation, but it is not done in 100% of cases, far from it. Evangelos?
Yeah, so I would say that bladder cuff equals suture equals hematuria sometimes. Honestly, when you do the single postoperative instillation, you do it when you are confident to take out the bladder catheter. So usually when you are confident, it means that you don't have hematuria. So yes, you can wait until you don't have hematuria, I would say. That would be it.
Okay, perfect. And I think the question that you have from Jawad has been treated already. What would be the ideal time to give the single intravesical mitomycin after nephrorectomy? So you came over the paper. And there is one last question. In an obstructed single kidney patient with NMIBC, would you insert a PCN or double G stent? So it's going back to what you have mentioned about the trial you just presented during the webinar. So I think we are clean with the question from the box. So just one question in that case, Evangelos, would you consider, or do you in your practice in some upper tract cases with distal ureter treatment, do you realize, I would say, your distal ureterectomy also and reinsertion of the ureter? Maybe in elderly patients where there are difficulties with, or you are afraid to, I would say, encounter renal insufficiency?
Yeah, I think the question is on segmental ureterectomy and especially distal ureterectomy for, let's say, pelvic ureter upper tract disease. I think that the guidelines are quite clear. This is a conservative management. So in case of elective choice, it has to fulfill the cases of low-risk disease. If you are in the imperative scenario where you have a renal failure or a suspected after radical nephro-U renal failure, then of course you can discuss it, but it has to be balanced between the pros and cons of a potential higher risk of recurrence rate.
Perfect. Okay. Frederick, one question, which has nothing to do with the case of Evangelos.
Okay.
We are discussing difficult cases in bladder cancer. Do you, I'm coming back to you about that because I've seen that recently in my practice. How do you deal with a bladder tumor in a diverticula? That could be tricky because we all know that the frontier, the blurred borders between non-muscle invasive and muscle invasive can be, I would say, difficult. So any tips and tricks
yes,
about bladder tumor in a diverticulum?
Well, it's a very good question because it's a common problem, and based on what you mentioned with the lack of the trusser muscle in the diverticulum. One aspect I would argue in favor of is doing a good and strategic and accurate transurethral resection and evaluating the whole bladder. So if the patient has a suspicion of high-grade disease in the voided urinary cytology, such as a Paris 3, 4, or 5, you should be eager to rule out, for example, carcinoma in situ in the prostatic urethra, do a PDD or NBI to increase the detection of CIS in the bladder. And then based on what the radiology looks like, I mean, the CTU, is this already an extravesical tumor, which is not infrequently seen in bladder diverticula? Evaluate what you are going to do. Are you going to take a biopsy and rule out high-grade disease elsewhere in the bladder to possibly treat the patient with a diverticulectomy, which is one option if there is a tumor in a diverticulum. So the diagnostic workup is the basis for the treatment discussion at the MDT. But then there are so many scenarios depending on the size and what you think and the grade. So it's merely a separate webinar, isn't it? These are really tricky cases, and in my experience, some of the patients where you do diverticulectomy, they have later muscle invasive recurrence in the bladder. So it's a dangerous disease entity that requires extra attention.
Okay. Any final words on your side, Evangelos, before we wrap up the webinar?
No, thank you very much for the nice discussion, and thank you to the European School of Urology for this very interesting webinar.
Okay, on your side, Frederick, any final comments?
No, I would just like to thank the listeners and you, Evangelos, and the ESU for this opportunity. And I think we're done. Every
good thing has to come to an end. So we will close this webinar. We'll thank once again Jurgita from the school for organizing everything. There is probably you can send your feedback to Jurgita and the school if you want any suggestion for any change in the course and in the design of the webinar. We are always happy to improve the format. And you can check on the website, uroweb.org, the school program for the upcoming webinar dealing with all the landscape of urology. So thank you very much. Enjoy your day or your evening according to your location on Earth. And see you soon on the EAU channels. Thank you, Frederick. Thank you, Evangelos.
Thank you, Morgan.
Have a nice evening. Goodbye, everyone.